All right. Thank you all. All right, let's go ahead and get started. Thank you everyone for joining us today. It is Statewide Lab Partnership meeting.
They got rid of
And just be aware, go ahead and mute your speakers if you could, but don't hesitate to ask questions.
Distracted. Everybody was distracted. I saw them sat down.
And we would also love face-to-face.
And then tell somebody, and then
Feel so willing to share your video. We would love it.
Much out of
We are going to ask.
Karen,
Go ahead.
I can't hear you. Could you go ahead and repeat that?
So if hearing is an issue, let me change my speaker.
I think it was just interference from other callers. I think you're good to go now.
All right, so I was just making comments about webinar etiquette to mute your speakers and but not to hesitate to chime in if you have a question. Also, we are recording today, so that will allow us to place this on our website, place a link on our website. So if we can go ahead and get started, I'd like to start with introductions of all of our DHHS staff and looking through to see who we have on today. Robin, would you go ahead with your introductions?
Sure, Robin Williams. I'm the one of the respiratory disease surveillance coordinators for the state.
Yes, we'll be talking to you more soon. Thank you. And who else do we have on? Sadie, go ahead and introduce yourself.
Hello, everyone. I'm Sadie Opagard. I'm one of the enteric epidemiologists along with Brianna Block. And yeah, this is my season, enteric season.
All right. Thank you. Is Matt on yet?
I don't believe so, but
He
I'll
will
check
be.
and see when he's coming from another meeting, so I'll check on that.
That'd be fine. And with that, I think I'd like to turn it over to our NPHL staff. Pete, are you on the line?
I am here, Karen, and
Okay.
I'm here to answer questions if they come up. Obviously, there's a lot of things going on right now.
Yeah, yes,
So-
a lot to talk about.
Yeah,
Tony Goldenstein, are you on?
Yes, I'm on.
Excellent. Thank you. And Brian Lenz, are you on?
I am on.
Perfect. Yes. Do we have, and Emily, I believe, is also on?
Hi, Karen, I'm here.
Yep, just talked to her a minute ago. So I think I've got everybody from DHHS too.
Well, we have Jeff Hammock, the vector-borne disease
Excellent.
epidemiologist, and Allison Kieser-Matoba, who is our vaccine preventable disease epidemiologist.
All right, thank you. I do not see them on my list, but it keeps changing. So I may have missed them. I apologize regarding, is Ishrad on at this point?
No.
Okay, well, we've got more than plenty to talk about. I think what we'll do is we'll start in on, and if Matt's not on, we'll skip COVID and start in with any updates that, and is John on? He may not be on.
Oh, there's the mute button. Yes, I am.
Okay, thank you. I didn't see your name either. I apologize. Go ahead. John, what can you share with us about current COVID situation?
Certainly. So I will try to leave as much of the Delta strain information out for Dr. Donahue. By and large, the big news of the day is Test Nebraska as a program is winding down. Actually, yesterday was the final day of collections. I would anticipate that St. E's and Becky Kroner over there We'll be running the last handful of specimens today, maybe tomorrow, depending on when they arrive into the building there. By the end of this week at the latest, all of the results for Test Nebraska should be released, and no more testing, no more operations will be occurring over there. The equipment is going to be boxed up. It's going to be sent to Omaha, where it will be put to use here for hopefully something that doesn't look like a new fall wave. We're going to be ready over here at the Public Health Lab for testing to pick up the slack as far as what was going on over at Test Nebraska. As it stands right now, the Public Health Lab is following up with the testing HON from late in June, talking about exactly which specimens are being specifically requested to be sent into the Public Health Lab. By and large, these fall under the handful of categories of reinfections, potential potential vaccine breakthrough, any hospitalized patients or suspected, any hospitalized patients with COVID-19 or suspected to have COVID-19, confirmation of presumptive positives or presumptive negative results using antigen tests, as well as testing as requested by the local public health department. I've reached out to a number of the health departments already, as well as a handful of the laboratories to say, please continue to send in specimens to the Public Health Lab. We will perform obviously any confirmations that you might be requesting, as well as sequencing for any specimen that is both positive and has a sufficiently high viral load. If your providers have any questions about specimens or about potentially variants in the specimens that they're collecting, please continue to send them in. If the public health departments are asking, please send them in. Additionally, if you would please send in a small sample of your positive specimens in a given week. This will allow us to keep an idea on what all is circulating in the environment right now. As we're seeing the Delta strain become the predominant strain throughout the state, it becomes ever more important to be able to track how much we're seeing in a given area, as well as as clusters are occurring, especially once the school year starts again.
Thank you, John. Just to reiterate, you're saying you don't necessarily need every positive in the state. However, a good sampling would be good for sequencing. Do you have any criteria in regards to maybe hospitalized patients or such?
Yes, I will drop the testing HON in the chat here. I believe that I'm able to do that. But again, as mentioned in the HON, DHHS is specifically requesting SARS-CoV-2 testing be ordered and sent to NPHL under the following circumstances. Number one item in that list, all patients hospitalized with COVID-19 or suspected COVID-19. Let me see what I've got here. And then the sixth item on this list of 7, confirmatory testing of presumptive positive or presumptive negative results from SARS-CoV-2 antigen tests. And I believe this presumptive negative would fall under primarily negative but symptomatic.
Okay. Yeah, that makes total sense. All right. Thank you, John.
John, this is Brian Lenz. One thing I didn't hear we talked about this morning at the UNMC meeting for outreach was COVID testing continuing for Charles Drew, One World, and the Ponca tribe. Is that something that the state is still going to be involved with, as well as nursing homes?
Yes, I will go down the list on these. For the FQHCs, One World and Charles Drew, as well as I believe we have Midwestern up in Norfolk, as well, Capwin Community Action Partnership out in Scottsbluff. Certainly, we will continue to send collection kits and maintain testing capacity for all of these FQHCs. Additionally, for any of the tribal communities in the state of Nebraska or with footprints that have any sort of footprint in Nebraska, we will continue to offer testing and reflex sequencing on any specimen sent this way. Fred Leroy, I know they have a handful of community clinics as well. We will continue to supply them.
Awesome. And what about long-term care facilities?
Certainly, for long-term care facilities, while we are not able to assist with routine testing, since we are not able to assist with routine testing per CMS guidelines, the Public Health Lab and DHHS continue to be available for confirmation testing for antigen tests that come through. We're also going to be available for local health department requested tests, such as in the event of an outbreak or recommendations from ICAP over at Nebraska Medicine. We can also take one-off specimens if there's concern without an antigen test. We can certainly take specimens here and there for it.
Thank you very much.
Any other questions for John?
Say, John, this is Pete. Just to clarify one thing, you gave a good overview on what's going on. I think the key for us is that we're not doing surveillance testing. The Public Health Lab is not supposedly involved in any surveillance testing. That's the key word.
John, this is Tony Goldenstein. If we get a nursing home or an assisted living that's asking about it, should we direct them to check with their local health department first?
Yes, the local health department and their preferred infection control authority, either ICAP or if they've got an associated hospital or a clinic with them, their infection control prevention team. Yes.
Okay, so ICAP or their health department.
Yes.
Okay, thank you.
Other questions? Okay. I was hoping to have Ishrat on today because we did have a couple of cases, obviously of reinfection that I wanted to speak on. That can be another time, of course. It has also come to light regarding colonization protocol. We haven't really heard about resistant Enterobacter ACE through COVID. However, we just want to make sure that keeps on the spotlight. That protocol probably will be rewritten as we do have a change of staff at DHHS. So, and maybe even a difference in protocol as well. So we will table that until next time that we can have Ishrat on, or if she comes in at a later time. So I thought I would bring up right away the discussion about monkeypox. So I know that here just on Saturday, we did have, I'm going to try to share that.
Hey, Karen,
Yes.
Dr. Donahue will be on at 12:30. So
Okay.
He probably wants to hear this. So could we go to possibly, Jeff
Yes.
or Sadie until he joins?
Yep, be happy to. So we'll skip through monkeypox and move on. Yes, Jeff. We have had some interesting things happen in Nebraska this week. It's been crazy at NPHL in regards to shipping off specimens to CDC. So Jeff, if you could kind of share what's going on.
Thanks, Karen. Hello, everyone. Just some of the stuff that's been Karen's kind of talking about being shipped off and stuff is we've been seeing a number of tick cases in particular that are being tested, but they're being tested for the wrong organism. We had one case where the provider had ordered Lyme disease testing on a patient, but when we were reviewing the case, looking at the signs and symptoms, it was pretty convincing that this wasn't a true Lyme disease case. It actually seemed to be more of maybe a spotted fever or ehrlichiosis case. And after we got the results back, we did have positive ehrlichiosis serology. It was very, very high. So, I guess the real big thing is, maybe if you have providers kind of ordering it in, test results in, maybe just, I don't know if there's a way, but to remind, hey, maybe look at some other tick-borne diseases besides Lyme disease. Not everything is Lyme disease when there's a tick-borne disease. Not every tick carries Lyme disease. In fact, with some of our, a little bit of a pilot project we did with tick surveys this year, we only found one black-legged tick. And out of the over 2,000 ticks we collected, the majority were dog ticks and Lone Star ticks. And these are the two primary vectors for spotted fever and in particular, the American dog tick for spotted fever rickettsia. And then for Lone Star ticks, they're the primary vectors for the ehrlichioses. So, that's just kind of maybe a reminder, to be on the lookout. We did put out a health alert at the beginning of the season just to remind providers of it. But, it looks like maybe some providers just are forgetting that or maybe just aren't remembering it. So that's just something to kind of be on the lookout for if we're suspecting a tick-borne disease. Not everything's going to be Lyme disease. Not all ticks carry Lyme in particular. So, the majority of ticks that we see are these ones that are going to carry rickettsias or ehrlichioses. So that's something to kind of keep on the radar. We certainly do have a couple, 3 counties that we know are considered established for black-legged tick, which are the primary vectors for Lyme disease. And that's Douglas, Saunders, and Sarpy. But outside of that, with some of our tick surveys this year, we only found one black-legged tick at one location. So just kind of a reminder there, that it's one of those things, providers really got to be cognizant of, what to look for. If, the symptoms aren't matching up with Lyme disease, maybe checking for other tick-borne diseases that are more likely prevalent in the state. So that's the major thing that we've had here the last couple of weeks is just some interesting things while we were doing investigations for Lyme disease cases. These signs and symptoms did not match up with Lyme disease. They matched up with either these rickettsias or ehrlichioses. So just kind of something to kind of keep in mind. And we have seen a number of ehrlichioses positives actually coming in the last couple of weeks. In fact, I think we've had about 3 or 4 positive tests come in the last 2 weeks. So we're certainly seeing an increase there, which is good. At least some providers seem to be, on the lookout for it as well, along with the spotted fever. So I guess, Karen, that's kind of what I have in terms of the kind of interesting cases we've been seeing. I don't know if anyone has any questions or anything else that they'd like to ask.
Hey, Jeff,
Go
have
ahead.
you seen any West Nile at all in the state in human?
Nope, we have no human cases to date. We have had, tests certainly coming in, but they've all been negative or either just IgM negative but IgG positive, so some exposure in the past at some point. We have had 2 positive mosquito pools that have popped up, and we are working on getting the HON out here. Hopefully, I think tomorrow is the plan, just to let the medical community know, hey, we've had our first 2 positive pools, so be on the lookout. Human cases follow these positive pools, and this year we're about 5 weeks earlier for our first positive compared to last year. Last year was a little bit unusual in that it was, a little bit later in August when we had our first positive. So that was a bit unusual. This year, it kind of seems like right now we're kind of more on track for what is, normal for Nebraska, quote unquote. So we'll kind of see how it goes from there.
Thanks, Jeff.
So on
Any
that,
questions for Jeff?
yeah, so you're saying tested coming in, is that PCR? Are they running IgG, IgM on the ehrlichiosis or just serology, or what are they doing?
So it's been a combination. So we've had PCRs that have come in that have been positive. And then on the ones that we've collected, one of those was serology. So we tested, we got tested for spotted fever, IgG serology, and Ehrlichia IgG serology. And the spotted fever serology was negative, and then the Ehrlichia was greater than 1 to 1,024, the titer value was. But it's been a combination for the other stuff we've seen kind of coming in. It's been a combination of serology and PCR.
Jeff, this is Karen. Would you recommend that our laboratories, if they see a specimen come through for one of these unusual tick-borne diseases, should they have their doctor confer with you? Is that something that we'd like to see go through the state to make sure that they're ordering correctly?
I don't know if we need to send it for us. Like I said, it's just been a couple of these cases where we've seen, a lot of providers, or not a lot, but these couple providers that were just ordering for Lyme disease testing because the patient had some symptoms and had a known tick bite. So, like I said, we did put out a HON, and I don't know if we just, maybe just need to reiterate, make sure that providers are, you're testing for the thing that's most likely to be there. Just having a history of a tick bite and some signs and symptoms, you really need to make sure that, that the signs and symptoms are matching up with what you truly think it is. Just having a known tick bite and no tick to really compare to, then just testing for Lyme disease, but nothing else, it probably isn't the most appropriate way to do that. You really should have a thought process on what is out there and what isn't. And like I said, by far, spotted fever and ehrlichioses are typically, what's going to be endemic here in Nebraska. Like I said, we do have a couple counties where we've had established populations, but these are very kind of patchy in these locations where they're at. So it's not like they're widespread across the county at this point in some of these areas. It's just very patchy along, especially river corridors. Whereas these other species can be, pretty widely distributed from what we're finding out with some of these kind of very limited tick surveys we've been able to do. Certainly dog ticks, those are very, very widespread across the state. And in some areas, we're starting to see where Lone Star ticks are also very widespread in certain areas, and more so than we kind of initially thought. We're finding out we've even had some specimens individual specimens we've collected up all the way to the Nebraska-South Dakota border, with just this kind of this piloting of this tick surveillance for Lone Stars. So certainly seems like we're seeing a little bit more there. I know there was the Department of Ag entomologist last year had done some limited tick surveys and even found a couple of specimens, not enough to consider established in the county, but all the way out at one of the sandhill counties at the kind of the national forest area out there. So I think we're kind of seeing it a little bit further than what we've kind of recognize it as, just because we haven't had funding to really look at ticks in particular, but that's something we're hoping to kind of alleviate here as we go into the future and do some more intensive tick surveys.
Say, Jeff, would it make sense to send out another HON as a reminder to say this is what we're seeing now in Nebraska as a reminder?
I can certainly talk with Dr. Donahue about maybe going forward and just kind of maybe reiterating, not every tick bite is a Lyme disease case. You got to really have that the signs and symptoms and that high suspicion that is indeed what that is.
Sure.
Because as I kind of mentioned, these couple of cases we've had with Ehrlichia, the signs and symptoms just didn't match with Lyme disease. They more closely matched a spotted fever or an Ehrlichia in these two cases. So
yeah, I just don't think the physicians think that other things are out there, and you've certainly seen it. So a reminder would be good to say that we do see these other things in Nebraska.
Yep. And that's something, like I said, I'll talk with Dr. Donahue about and get his kind of opinion on it and his thoughts, and then kind of have it from there.
Sounds good.
Yep.
Thank you, Jeff. Sure appreciate it. Any last minute questions for Jeff? We'll move on to Sadie. And Sadie, if you want to just give us, I know you always have your surveillance meeting that or call that you do share with the laboratories, but if you want to do any further updates or quick review.
Yeah, so hello everyone. We know most of the labs nowadays are using some kind of multiplex PCR panel, whether it's BioFire or the Verigene. And basically when there's a Shigella detection, it is shared with the EIEC, intro-invasive E. coli. So when there's a detection of Shigella EIEC, it's detecting a gene that's on both Shigella and EIEC because they're both clinically and genetically similar. We're asking if labs have the ability to reflex culture to attempt to isolate out the Shigella in an effort to distinguish those two. Additionally, if you can reflex culture to that Shigella, if you're able to isolate it, we do want all isolates that are not Stonii sent to NPHL for further testing. And I know there are a few labs that do reflex culture these detections, but the majority of labs do not do that. So I was hoping if you have the capacity to do that, you can do that. But what do you think, Karen, Emily, Pete, any other additional things you want to add?
You know, Sadie, thank you for mentioning that. In the past, we haven't necessarily promoted sending that, but I can see where some of, as you have shared, that about 70% of your cases anymore are the Shigella EIEC combinations. It's tough to isolate these organisms, especially if it has to be shipped first to NPHL. It seems to lose a lot in recovery when they sit several days in that transport media. It's tough to say. That's why I think that if laboratories have that ability at this point now, granted, before we didn't always have them do it, maybe we need to rethink that whole issue. I'd like to hear what other laboratories say and would like your comments, please.
Hey, Karen, this is Pete. We still, look at Shigella as being a patient management issue, possibly for susceptibility testing. So public health is really not here to do cultures of Shigella from these NAT tests, unless the local health department or the state epi would like that to be done. So I want to keep that out there. You know that Shigella comes in buckets. We can get sporadic ones that show up, and then all of a sudden we can get 100 of them. So it's kind of like we just have to kind of watch that.
Well, and that's very true. As a reminder, what I didn't mention before is that we don't want every Shigella, because if they're, especially Shigella sonii, that is not on the Title 173. So
Right.
those are not required to be sent to the public health laboratories. However, we have had in the past, especially surrounding states of Nebraska, we've had some Flexneri outbreaks. I am concerned that we are missing some of those. So again, I think each lab needs to weigh what works best for them, but also epidemiologically or patient-wise, do they need to have that MIC? And if that's true, if you have to culture it to recover, could it be sent to NPHL is really our request at this point. So
Right. And I will say that culture of Shigella from these stools is not an easy thing to do, that our positivity rate is well under 50%. So even if we do it right away, get them from our clinic here at Nebraska Medicine, for instance, we still can't culture it. It's really difficult. So I'm just saying is that's a tough one.
Yeah. So I understand that, and it's something that we just have to deal with. Is it because, Pete, that the multiplexes are so sensitive that they can pick these up, even though the counts may not be very
It
high?
could be, but it could be the EIECs too that are out there. So we just don't know.
Yeah.
And we have no way of detecting that and identifying it. So it's hard to say. Very hard.
Also,
right.
can I just add, since we were talking about Title 173 with enteric season coming back around, I think a lot of the labs have been so focused on COVID that they might be forgetting to send some of our organisms that are required to be sent to NPHL. So just maybe look over the quick guides that Karen has sent out to labs, make sure you're sending Salmonella, Shiga nuclei, Cyclospora, Cryptosporidium. Look it over, make sure that those are getting sent. We've had to call and contact a lot of labs to make sure specimens are getting sent.
So Sadie,
Right.
since you mentioned cyclospora, we've seen some sporadic cases showing up. I think we're up to 9 here that we've seen.
Yeah. I think Brianna wants to talk about it.
Yep. Hi, can you hear me?
Yeah. Hi, Brianna.
Yes,
Yeah.
Yeah, I was going to mention cyclospora. The good thing is last year at this time we had 65 cases, and so far this year we have 10 up to this point. So yay. That is good. But
You better knock on wood. Brianna.
yeah, I know. Or we're just getting a late start on it, which
Yeah.
that's probably what's going to happen. Right now it's kind of sporadic. They're across the state among, different labs and different local health department jurisdictions. We're attempting to interview all of them. We have 2 that are pending. We've had a couple that are that traveled to Mexico. So those are actually excluded from CDC's case definition because they only focus on domestic cases. So the ones that we do have information for, they're reporting typical cyclospora risk factors, lots of leafy greens, fresh produce, herbs, fresh vegetables, etc. I know CDC and FDA, they just opened, they actually have an investigation foodborne illness table on FDA's page. So they did make it public. They are investigating the cyclospora cluster. Traceback has been initiated, and it looks like sample collection and analysis is initiated as well. But the source of infection is not yet confirmed. So,
Okay.
yeah, and it looks like most of the specimens have been sent to the public health lab. The 2 that just got reported today, you guys should be receiving hopefully. So just a reminder to send those cyclosporas to MPHL, please.
And to our laboratories that do test for these specific items, I know that it's best to figure out a system that works for your workflow. It is, if you get a positive in your run, is it something that you have to go digging out a specimen just to be able to send it to us? Is there a better methodology that could help in getting those specimens to us? Think that workflow through and see what works best for you. So, any questions about cyclospora? Any questions about Shigella or multiplex testing? All right. Is Matt on yet? Robin, do you have anything else you'd like to add?
Well, I did just want to mention that, the Nebraska emergency order is done, but COVID is still reportable. So that emergency order has nothing to do with reporting of COVID positive and negative laboratory tests. So that still is a requirement. Coronavirus has always been in our rules and regs for reporting via ELR, but as the director, the previous memo, positive and negative coronavirus reports are still reportable. So you can tell your friends and still send us lab tests, because unfortunately it's not going away. And we're planning for more cases soon. So as much as people can get onboarded with the electronic spreadsheets or ELR, the easier it will be for laboratories. So if you need to get involved in that, please contact us and we'll help you out again if you're not already going. But just want to re-emphasize that.
Thank you, that's good. And also maybe a reminder that that list, the Title 173, is located on the NPHL website. Just have to look to the left to the menu items and you'll see it there, and just click on that particular tab. As Sadie recommended too, when it comes to the cheat sheets that we have for laboratories, those also can be found on our laboratory. If you don't have that listed or posted on your laboratory bulletin boards anymore, please dig those up and make sure that they're posted for everybody to see.
And we are in the process of revising rules and regs. So there may be some changes that come about. Of course, you know, we've just submitted our draft. So it could be a long time before things actually get put in place. I did also want to mention RSV. Because RSV has increased here pretty substantially in the last few weeks. I did start putting together a little RSV report as much as we could, and I did request that if you are not submitting ELR reports, that if you could and are performing RSV testing, to go fill out the weekly survey for RSV lab reports again. I know this isn't typical for us to do this kind of thing in the summer, but it's there for these kinds of situations. So I would appreciate filling out the weekly online survey for RSV, throw flu in there. I just had a positive flu come across my desk and I'm like, what? And so have to find out what's going on with that one. But
way too early, Robin. Way too
I
early.
know. And so again, if you see any unsubtypables during the summertime with influenza, it could be the swine flu. Make sure that capturing any agricultural contact with any positive flus, and we'd like those sent to the public health lab for typing and figuring out what that possibility is. There has been some up in the Northeast, or Northeast West, or the Midwest, but you know, Ohio, Michigan think that they're Midwest, but up in that area. So please, if you get any flu positives, we'd like to see those.
Hey, Robin, it's not too soon to be thinking about the fall surveillance sentinel program for influenza. So keep that in mind. We don't want to wait till the last minute. I also want to mention that the Public Health Lab continues to multiplex COVID and influenza tests. So all of our testing is done looking for influenza. We have not seen any since, I don't think we've seen any since last fall, but we're continuing to have a surveillance program in place for it. So I'm afraid flu is going to be an interesting one coming up. That's my thought anyway.
Yeah, I think we'll see it again.
I'm sure we will.
And so we will want to, you know, send in specimens at that time. We'll have more correspondence here in a month or so.
Yep, thanks.
Robin, I just wanted to add, thank you for notifying us of that flu. If you, of course, could forward it on, we would be very happy to subtype that for you so we have an idea of what may be going on. I know that's not always possible. And I just wanted to note for the laboratorians here, if your clinicians ask you about testing ideas and that kind of stuff, don't forget about the other circulating respiratory viruses. I think this RSV situation has really brought that to light. The CDC actually released a HON about the increase of RSV back in June, that it was noted in Region 6 and down in the South. We are, as Robin noted, seeing a significant increase here. Unfortunately, I think most individuals are focused on COVID and forgetting about the other respiratory viruses circulating. So especially in the very young or elderly populations where a virus such as RSV can be extremely detrimental, please make sure that your clinicians are thinking about these other pathogens out there and testing appropriately.
Great reminder, Emily. Great reminder. Thank you. Anything else? Any other questions about any of the foodborne? All right. I still don't see Matt, Robin.
Okay,
We'll keep
well
going.
then,
We'll keep
let
going.
us keep going.
Yep. Emily and Pete, since we're on the topic, is there anything else you need to add about the COVID-19 in the meantime? I think you've said it pretty much all.
I think we've said it for COVID.
Yes.
Emily, do you want to share on the monkeypox issue?
Robin, do you want me to talk about monkeypox or wait for Matt still?
Actually, I think Derry has one thing to say real quick.
Yeah. Hi,
Oh, can you
Derek.
hear me?
Yes.
Okay, not about monkeypox, but I just joined, and I just wanted to throw out the reminder to the lab staff that just are on this call about the lead care 2 recall for the point of care devices that can analyze capillary blood for blood lead levels. There are a few laboratories and some hospitals that use that machine, and there was a FDA recall for certain test kits distributed between October and June of this year, and October of last year and June of this year, and quite a few test kits and tests were affected. The recommendation is to throw out those test kits and retest children if they had been affected by those test kits, or if it was unknown which test kits were used. So we sent that HON out last week to hospitals, laboratories, clinics, and just a reminder to if anyone's on that uses those machines, that you see that you respond to that recall and contact DHHS if you have any questions, or myself, Derry Stover, and I can put my contact information in the chat box.
This is Teresa Fowler. Just so everybody does know, we have seen One World has reached out to us, and a couple of our other clients have reached out to alert us that we'll see an increase in testing from those sites for the lead card. So
yes, thank you.
Clients are reacting, which is good.
Yes, yeah. I'm kind of anticipating a shortage of the lead care test kits from Magellan as the company, and there are ways to analyze capillary blood outside of the point of care devices, either with whole blood or like with a filter paper card. And those can be analyzed without a lead care 2. So our whole goal is to not slow down lead testing because it's a critical kind of preventative type test, and we don't want that to slow down more than it has during COVID. So we want to keep up the testing and find ways that we can do the testing, whether it's through the UNMC or other methods.
This is Tony Goldstein. Has anybody heard about reimbursement for these recollections?
Yes, thank you for bringing that up. We proposed that question to CDC, and in their response, they said that they had confirmed for those children that are enrolled in Medicaid, that Medicaid would pay for those retests, and provided us with contact information about who to contact for more information, or if there's any problems with that. Outside of Medicaid, I guess it'd be up to the private insurers, and their decisions on that retesting. Hopefully they would pay for those, but if there's any issues there, we can try to reach out to those insurance providers if they're like in the state or whatever, that to make sure that those tests get covered for reimbursement.
So who at Medicaid, or who should I refer clients to with this question, or our own?
I would to me, and I can act as a liaison with you know, the CDC and CMS.
Okay, thanks.
Yeah.
Derry, thank you for that update. Very important. If you're a laboratory that does do the point of care led testing and have not heard about this, it's something that we would like to bring to your attention, and you can let your physicians know. So you can contact Derry or us, or I'm sure any of us would be willing to share that information with you. So any more questions for Derry, please? Thank you. Thank you very much. All right. Speaking to client services, good to hear from you, Teresa. Do you have anything that you would like to share?
Well, I just, want to make sure that people know we're still able to accept COVID testing. So I'm sure that was probably already discussed this morning, but the total vaccine clinic is closing. It was supposed to be, that's the clinic out at 144th. It was supposed to close the end of July, but now it's got an unknown ETA for closure. But we are working on changing some of the links. I know there's been some people that the state has been sending to the TVC, but the links will change and can go to our South Tower on main campus now. So we'll send all that updated stuff out through John when that day comes. And then I also want to make sure it's on everybody's radar that regional lab, because we're not considered a hospital, we are not on a vendor priority list for the blue top tubes that do PTTs and ProTimes. And so we are completely out of that supply and unable to get any. And so I guess want to make sure that, I didn't know if it was on the state's radar and if they were trying to secure any for hospitals and EDs, or if that's maybe not a problem where hospitals and EDs are able to get that supply.
That's.
Oh, this year from Syracuse, I know in the small hospitals, we've had trouble and we've been sharing. We've been just, when someone gets a case in, they split the case and we've been shipping them around. I know I've shipped to 4 or 5 different hospitals. Now, since then, a lot of those hospitals have got their supplies and have returned their shipments back to us, but and others have been doing that. So I think like Lex and Valentine, we've all been hurrying, but I think we've been doing a pretty good job amongst our lab community. We've been sharing kits, sharing tubes. We've been kind of crossing crafts between BD and Griner, whichever ones we can get. But I know that most of the hospitals are pretty set because we've been able to share.
Okay, good to know. That's my major concern. I know from a clinic perspective, they can either send to a hospital or they can use the finger stick for the ProTimes to measure that. However, I just wanted to make sure it's on everybody's radar. What we're looking at now is maybe a supply that's not BD or Griner, and maybe internally validating it to see if it will work. But yeah, that's good to know that hospitals are sharing. So
Teresa, I'll reach out to our federal partners and see if they have any ins for anything, maybe in the national stockpile or anything to assist in this.
Yeah, and even if we did secure some, it would be mainly for our hospital clients, because we do understand that that's where the need is, since the supply is so short. Unfortunately, we can't just 3D print a coag tube, so it's pretty trying for all of us.
I'll see what I can do with the contacts we have.
Thanks.
Do we have any other laboratories that are having issues that we've not heard from? And don't be shy about it. You can also put it in the chat if you are experiencing any problems. All right, Well, meanwhile, I think we are going to back up. I want to welcome Dr. Donahue. Glad to have you here. We have held the two big topics just for you. We do want to discuss the Delta strain and get into the topic of monkeypox. Matt.
Hey, Karen, happy to talk about each of these. If there's any specific questions, feel free to post them in the chat box, but I'm happy to give an overview off the cuff too. Delta variant is in Nebraska, and it is our predominant strain. And we began the transition about 2 months ago. Let me see if I can share something with you, because a visual is worth 1,000 words.
Do you want me to hold on? I'll share my screen with you.
Well, I've got us pulled up here too. So let me. Yep. If you stop sharing, I can take over. There we go.
Yep.
And apologies for the delay here. Had two others, and one of them just kept going. Share screen.
No problem.
Here we go. So guys, more than the counts of each of these different variants, what we try to look at is the proportion, right? And I'm gonna get these heads out of the way so you can really see this. I show this visual on a few of the other calls, but there's two main things that you can see here, and it's this beginning all the way back here in January with this dark blue bar, and this transition over to light blue. That was our transition from wild type over to B117. And then you can see more recently this dark purple bar that really started taking off in May and June. We first identified B1617 or Delta variant here in late April, early May, but it was really in late May, early June that it started making up bigger and bigger proportions of all of our sequences. And I'd say for the last about a month now, it has been our dominant strain throughout the state. So that's the main visual. I don't need to take you guys through many others, maybe just one other here. So when we talk about the proportion of all of our sequences, or of all of our positive specimens that are sequenced, a gold standard threshold has been about 5%. And we've done well above 10%, I think, all the way since we started ramping up back in January. We've really pushed. NPHL has done a ton of work, and Creighton helped out a lot too with increasing sequencing volumes. We got all the way up to 27% of all of our positives in the state sequenced, and we've been well over 10% for the last several weeks. This little 9% down here will only go up as we get more specimens sequenced from that week. That'll be well above 10% by the next time this is updated too. So all that to say is, I think in Nebraska, we have very good visibility into what strains are circulating. And that's because a lot of the work you guys are doing. So appreciate everybody's help sending specimens to NPHL and to Creighton for sequencing. Now, what makes Delta different? The key thing that we found with Delta has been it's more contagious, even than B117, right? Which allowed it to really outcompete B117 or Alpha. But more than that, the biggest question is, what does it do differently for vaccine-induced immunity? And is it able to break through vaccine-induced immunity at a frequency that could set us back? And it appears as though it does not yet. So we're seeing more vaccine breakthroughs with Delta variant than with other variants. But what we're finding is that even though there's more, those people still aren't suffering more severe illness. So the vaccine is still working to keep people out of the hospital and protect people from dying, even against this new Delta variant, which is the key takeaway, is that we are seeing higher amounts of mild illness for Delta variant vaccine breakthroughs than our other variants, but vaccine is still keeping those people from needing hospitalization. And there'll be exceptions to that. I know of just a handful, just a couple vaccine breakthrough deaths for Delta variant, but by and large, it is keeping people out of the hospital. Vaccines keeping people out of the hospital, even against Delta. So I'd say we refresh all of our numbers on Mondays. I don't have the most recent ones yet, but for all of our Delta variants and all of our P1 Gamma variants, about 30% of those have been vaccine breakthrough, and very few of those have been hospitalized or died. So I don't know what else to say about Delta for now. Are there any questions about Delta?
Do we hear any questions from the labs? I might have one for you, Matt, and that would be, there was a Lambda variant that started to show just recently. Do you know anything about that? And is that going to be an issue?
So there's with this whole new naming convention, right? It was B117 that first caused us to look at all of these different lineages and all these different genotypes. It was B117 that first stood out as this genotype has there's a substantial phenotypic change here where it is more contagious. So after B117, we started looking at all these and P1 gamma, B1351, which I believe is beta from South Africa. Each of these had slight phenotypic differences. And then Delta came along and it's clearly taken over both in Nebraska and globally, which has had the most phenotypic difference so far. It's been the most contagious so far. Besides that, so these are all variants of concern. Besides that, there are multiple variants of interest that both CDC and WHO are monitoring. And all that means is this is clearly a different genotype, but it's unclear what impact that might have yet. So it's a different genotype without a clear phenotypic trend yet. Lambda, I believe, originated in Peru and expanded quickly in Peru. Anything that expands quickly is outcompeting the other wild types in the region. I don't think it's clear yet at all what Lambda will mean on a global scale. We don't know enough to say how it will compete with Delta one way or another, except for we have found them. So we have a few of these Lambda variants, and we're watching those. We're doing extensive investigations around those individuals, just like we're trying to do around Delta. And that's really all. I think this last week was our first identification of these Lambdas.
Okay. Thank you, Matt. And if no other questions, we can go on to the monkeypox. Are you willing to introduce that topic? I know Emily's got a lot of good information to share for you.
Well, has Emily already shared some of it or not?
Not
Where
yet.
am I starting here? All right.
From the beginning. And I can share the document that just came out on Saturday if you would like.
The Han? Oh, perfect. Beautiful. So this has all the bullet points in it. If it looks like we only have 2 minutes left, so I'm going to try to rattle through some of these just for the highest level overview. But you might know smallpox was eradicated in the 70s, right? So this is smallpox has the characteristic macules that turn into papules that turn into vesicles, was very contagious, could be spread by respiratory droplets or by contact, and had a very high case fatality rate, ranging somewhere between like 30 and 60%, depending on comorbidities, age, vaccine status, etc. Smallpox, primary reservoirs humans, and we were able to eradicate smallpox in the 70s, and since then stopped vaccinating against smallpox in the 80s. And it was in the 80s then that people started seeing smallpox-like illness. Investigation uncovered monkeypox that came out of both Western and Central Africa, which looked very similar in clinical presentation to smallpox, but didn't cause as severe of illness. The case fatality rate for monkeypox, depending on the specific clade, is anywhere between 1 and 14%. So it's not as high as smallpox, but still pretty significant. I mean, a case fatality rate of 10% among children is something that's worth a lot of our energy and resources if there is a identification or an exposure. So smallpox vaccine actually produces immunity against monkeypox, which is a tool that we can go into this in our back pocket knowing. There's some brief background. 400 to 500 cases of monkeypox identified in Central or Western Africa overall, with one outbreak in the US related to prairie dogs back in 2003. Since then, we really don't do a lot with it. July 9th, a traveler flies from Nigeria to Atlanta to Dallas, presumably during his infectious period. And what happens next then is identification of close contacts that might be at risk of monkeypox, notification, quarantine, and isolation. CDC sends out travelers, identifies travelers who might have been at risk and gets those out to states. And Nebraska has not received any travelers associated with that case yet. So I think what's most important for us is to make sure physicians are armed with what this could look like. Although I think the risk is exceedingly low right now. We don't have anybody associated with this person who traveled to Nebraska.
Good to know.
There we go. So that's 2-3 minutes on monkeypox. hope that was sufficient for y'all.
Well, let's, Emily would like to share what she has found out from the CDC just this morning.
Sadie, I saw you put the HON down in the chat box. Thank you very much. We have received some emails here at NPHL about appropriate specimen types and what can be used for testing of this. And I am not ignoring your emails. I'm actually in discussion with the CDC right now. It seems that given the intensity of this situation, the CDC preemptively released a HON without discussing with their LRN Laboratory Response Network partners as to what appropriate specimen types would be. You can see through a series of clicks from the initial HON that they have prodrome testing, which allows for nasopharyngeal swabs, as well as tonsil swabs and even acute serum or blood specimens. There is no approved assay, either via LRN testing or as a CDC send out at this time on those specimen types. We have the ability to test once the rash forms, which usually takes approximately 1 to 3 days. But the CDC is scrambling currently. They are trying to put something together and release an additional statement about those prodrome specimen types. Just so everyone here knows, the HON also indicates that your laboratory response network, of which NPHL is for the state of Nebraska, has the ability to confirm monkeypox. We do not have that ability, actually. We can identify it as an orthopox virus causing the infection, but we cannot, without aid from CDC, actually confirm it specifically as monkeypox. We don't differentiate between the different orthopox viruses unless it is going to be smallpox or, the little cousin varicella zoster virus. So I wanted to put those 2 caveats out there. One of the big things to note is that, yes, we can test lesions if it comes to it, or the actual rash itself, the papules. The big thing to note is that do not put it in viral transport media. There is collection guidance for that from the CDC, and we can put that out as well. If anything were to come up, which Dr. Donahue has mentioned is not likely in the state of Nebraska, please be sure to reach out to both the state, DHHS, as well as NPHL. We will coordinate discussions with the CDC Emergency Operations Center, and we will discuss the best route of testing at that point. But this is something that has the ability to be high consequence. So we really may need to ensure that all parties are notified and kept in communication at one time.
All right.
Thanks, Emily. And let me just share that the LRN network, we aren't the only lab that can't confirm this. None of the LRN laboratories can. We do not have protocols from the CDC to be able to confirm it. So it isn't just us. It's the CDC is the confirmation lab.
As a little plug to NPHL on that, though, I would like to note, just for your guys' all FYI and a fun little fact about NPHL, we are one of only about a dozen public health laboratories across the entire nation who have the ability to perform in-house smallpox testing. And that is because our leader and man in charge, Mr. Pete Iwin, gets the smallpox vaccine and stays up to date on it.
I've rolled up my arms 4 times for that shot. So just to let you know.
Can I ask a question? If a laboratory were to send these, would they be considered category A's?
Good question. Let me consult really quickly my shipping Bible.
Okay, good. Yeah. I don't have mine in front of me. Thank you.
And monkeypox virus is a category A.
Okay, so I just want to make sure
But it's but it does not say behind it cultures only. So that means both specimen and culture. Obviously, we would never culture for it, but the specimen itself would be considered category A as.
Great. So I just want to caution laboratories that the only courier that's able to pick up category A's is ProMed. And so if you need a category A, you can't just send it with your normal courier. Sandra, I see that you maybe were going to try to send one with Mac, but he's a lab logistics courier. So just a word of caution there. And so if you need a pickup, just call client services. Make sure you tell them it's a category A. Otherwise, you have to FedEx them. Karen, you're on mute or something. Or I just couldn't hear you.
No, I can't
anybody
hear
else?
her either.
Oh, okay.
Yeah. But Teresa, thank you for that reminder. That's a great reminder for all of us involved. That's a easy thing to forget when it comes to shipping those specimens. So that's why we rely on you guys to be the experts. Thank you.
Can you hear me now? Okay.
Yes.
Yes, thank you, Teresa. I think it would behoove everyone to look to see what their shipping materials are and if they have sufficient materials. But that's just something we should always be doing. So with that, I think we should close out. Everything else on the agenda can wait for another time unless anybody has any questions. So last chance. And if I hear no questions, and I'm double checking the chat, I don't see any questions there. Then I thank everyone for being on today. We will see you next month, third Monday of the month. And let's hope it's quieter. Take care, everyone.
Thanks, Karen.
Thanks, Karen.
You
Thanks,
bet.
everyone. Bye.
Thank you, Teresa.